Okay, doctor, we can begin.
Hello everyone, a very good afternoon. I am Dr. Atma Ram Bansal. I am in Delhi, Medanta, in Gurgaon. My area of interest is epilepsy, that too especially refractory epilepsy. So welcome you all, and it should be more of a two-way communication rather than one-way communication. I'll try to adjust as many questions as possible so that I can also kind of learn and discuss. So as you know that epilepsy is quite common, but probably what we think it, in fact, it's more than what we think. It's almost 1% of the global burden of the disease, 1% of the population. And out of this total burden, you can say almost 30-40% are having uncontrolled epilepsy. And that's what our area of interest is for today. So what is refractory epilepsy? Is there any criteria? When should we think that this epilepsy is refractory epilepsy? So as per at least ILE, if you have tried two medicines, whether they are in combination or separate, and the person is not controlled, it comes in the heading of drug-resistant epilepsy. So that is the term we use, drug-resistant epilepsy. Previously, there was some criteria of rule of two, means two drugs, more than 2 years, and more than 2 seizures per month. So now the frequency is not at all in the criteria. Now they say any frequency of seizure which is affecting day-to-day life. And the rule of 2 years is also not there, because if somebody is getting daily seizure, you can't wait for 2 years to say that this is drug-resistant epilepsy. So when to suspect? Can we suspect from very beginning, or how to suspect that this patient is likely to develop drug-resistant epilepsy? So as per definition, if we have already tried two unsuccessfully, then it is drug failure. And another thing is, if you have tried two and are trying other medication, the chances of successful treatment comes down. So if with first medicine, the chances are 50%, with second maybe 60%, 70%, but next, third, fourth, fifth, as per Martin Brody, it is just 5%, but some studies up to 15% that out of patients who are not controlled with two drugs, maybe 5 to 15% patient may get control with trial of other drugs, otherwise they may not respond. Majority of them will not respond to new drug. But the question remains, is it really pharmacoresistance? Means when a patient who is not responding to medicine, is he having real epilepsy? Is it really drug resistant? Because many a times the seizures are not controlled because of epilepsy per se, but more because of non-compliance. So many a time we see in our OPD that a patient who is coming is well controlled. The moment he stops medicine, the moment he misses medicine, he is getting seizures. So this is not drug resistant epilepsy. This is non-compliance related epilepsy. At the same time, easily almost 15 to 20% of the patient are actually not having epilepsy. They are not having seizures, ongoing seizure because of epilepsy. They are having something what we say non-epileptic seizure or psychogenic non-epileptic seizures. So that needs to be ruled out before trying multiple medication. Third thing is misdiagnosis, means the patient was having something like primary generalized epilepsy or JME, and we were treating with something like carbamazepine. So those patients are likely to be drug resistant, not because that their epilepsy is drug resistant, because the proper diagnosis, syndromic diagnosis, and appropriate medication was not selected. Next is inappropriate use, means what? The dose requirement may be something like 20 mg per kg, and we might have tried only 10 mg per kg. We might have tried 2, 3, 4 medication, but all only in very, very low doses. So that also is something like inappropriate use of medication. Last point is something like lifestyle. So we do see a patient who is getting seizures only because he's taking too much of alcohol, maybe withdrawal related seizures. So in such patient is not true pharmacoresistance. So who are at the risk of pharmacoresistance? Can we tell about from very beginning that this patient can have? Or what are the things we need to know in our OPD practice to say that this patient is having drug resistant epilepsy. So first thing is, if anti-epileptic drug is failing because of efficacy, not because of side effect. Suppose you start carbamazepine and patient develops drug allergy. So it's not drug failure. Second thing is, if somebody is having very frequent seizures before starting treatment, such patients are prone to have drug resistance. A patient first time presenting with status epilepticus is more likely to have drug resistance. As you know that idiopathic epilepsy is like idiopathic generalized epilepsy or idiopathic Rolandic epilepsy, benign Rolandic epilepsies. Those epilepsies are more likely to have better prognosis. Third thing, fifth important point is this longer duration and family history. So what are the consequences of refractory epilepsy? So as you know that with kind of status, there are some changes in the brain, there are some change in the networks. But other than this, there are issues like comorbidities. Patient on anti-epileptic drugs may have osteoporosis, may have significant behavioral issues, even suicides, risk of accidents if somebody is driving. SUDEP is, as you know, it's a reality. It's not something we can ignore. Pneumonia related to post seizure aspiration, depression, anxiety, all those things. The biggest issue, at least in India, is the social stigma, relation to marriage, educational issues, vocational issues. So these are also very, very important issues. Actually speaking, in India, marriage is more important than driving, and that gets affected. Coming to what can we find in a patient who is having refractory epilepsy if we do an MRI? As you know that the most common thing is MTS, but there are things like DNET, and Indian scenario, hypoxic brain damage is the most important finding which we see in due to perinatal insult. So maybe because of obstructive issues, obstetrical care issues in the perinatal period, or neglect or home deliveries, it was definitely more common than any of the developed countries in India. And we could see bilateral posterior head region glasses causing seizures, and then cortical malformations. So suppose you are sure that this patient is having drug resistant epilepsy. How can you evaluate, or how that patient should be evaluated if you don't have that facility? At least what should be done for that patient? No doubt that there are a lot of challenges in epilepsy. There are issues, comorbidity, which we discussed, polytherapy. We do have 25 anti-epileptic drugs almost, and can we try all those 25? Not possible at all. Some drugs even can cause paradoxical aggravation. So main thing depends on etiology, syndromes, and what type of seizure you have. So what next? First step is the most important step, that is confirm the diagnosis. So if you are sure that this is drug-resistant epilepsy, then what we need to know is what is the syndromic diagnosis? What kind of epilepsy are we dealing? Just saying epilepsy is like just saying fever, that you have fever. What is the etiology of a fever? What is the etiology of epilepsy in a given patient? That is the most important thing. So how do we start? Suppose this patient is in a referral center where epilepsy workup is being done. The first thing is, like any case, history, then examination, then definitely investigations. Why history is important? History is important because we need to know the details, and each and everything is important. Why? Like a classical case of mesial temporal lobe epilepsy, the age of onset is in teenage. They have clear antecedents like febrile seizures. Their frequency is something like 1 per week, 2 per week, and they don't have secondary generalization that frequently. So each point can pinpoint to or help in making a syndromic diagnosis. Family history can help in something like JMA, or in patient with autosomal dominant nocturnal frontal lobe epilepsy. So all these things are important. Handedness is important from the surgical point of view. So all these details are very, very important when we are dealing with a drug-resistant epilepsy. Then comes another interesting fact is semiology. So we need to know how the seizure started. What was the aura? exact manifestation are very, very important. How it started and how it evolved and what happened in the post-ictal phase. So nowadays, as you know, almost 80-90% of the people have mobile facility with video recording when they come in your OPD. So those patients should be encouraged to record video at home. And by seeing the semiology, we can make a better diagnosis. So it's important to know each and every aspect because the aura is classical in MTS patients, some kind of epigastric sensation, something coming out of the stomach, fear, palpitation, those are very important in temporal lobe epilepsies. Then patient with occipital can have classical visual auras. So those are very important auras which help in localizing. Then next comes examination. So at least 2 points are very important in examination. One is neurocutaneous marker. If somebody is having refractory epilepsy and the moment you see the adenoma sebaceum, when the just near the nose areas, you are sure that this is tuberous sclerosis. And what you can expect is multiple tumors in the brain. A patient who is having clear-cut hemiparesis, you expect that contralateral hemisphere is likely to be abnormal on MRI. Today itself, I saw one patient who had infantile hemiparesis and now seizures. So I expect that MRI will show something, and it was a clear-cut porencephalic cyst. So the question is, after doing this history and examination workup, how to approach? The MRI is the most important investigation for refractory epilepsy. The management of refractory epilepsy is very, very dependent on MRI. And in this case, it is epilepsy protocol MRI. You know why it is important than a routine MRI? The reason is in chronic epilepsies, we want to see high resolution, thin slices sequences of temporal lobe, especially hippocampus. We do want to see all cortex from top to bottom in a very thin resolution. So we need to have something like spatial orientation in the sagittal, in the coronal especially. In the T2 coronal, we need to angle that cursor in a way that it is at the angle of hippocampus. Very interesting fact about MRI, which many centers where this epilepsy surgery kind of is going on, or where the comprehensive epilepsy program is going on. One is that 3 Tesla is definitely better than 1.5, as you know. But this 1 mm slices, coronal sequences, propal temporal cuts, these help in improving the quality of MRI and pickups. But remember, don't rely on MRI report. Your radiologist can miss many things, including MTS, especially if it's very early, can miss other lesions like cortical dysplasias. It's not that he's not experienced, it's that as a clinician, we always correlate clinically. Like small focus of infarcts can be missed by radiologists, but if we suspect lateral medullary syndrome, we can pick up better than radiologists. Because focusing on a single point always helps in making a diagnosis. So suppose our clinical localization or EEG localization is in the temporal lobe, we focus on temporal lobe and see if it is showing something in the parietal or occipital, then we need to go back to MRI, again ask the radiologist to at least specifically look in that area. And many times it has happened that report is changed based upon our feedback. It's not that they are incompetent, it's that they don't have clinical backup in the first go. So next important crucial investigation is video EEG. So what is video EEG? So as you know, video is nothing but simultaneous recording of video and EEG. Why? Our purpose is to record the attacks. Otherwise, video is not required. So first step, when we record it, our purpose is, are we dealing with epilepsy or not? If yes, what kind of epilepsy? Is it focal epilepsy or is it idiopathic generalized epilepsy? Third step, Is it coming from the right side of the brain or the left side of the brain? Is it coming from the temporal lobe or extratemporal? That includes frontal, occipital. So commonest is temporal lobe epilepsy. Then comes this frontal, occipital, and parietal is a bit rare. So purpose is to record all type of seizures as per history. How many seizures? Suppose somebody is having clear classical temporal lobe epilepsy. We just need to record 1 or 2 seizures. And if MRI is ipsilateral, spikes are ipsilateral, we don't need to record many of the seizures. But yes, suppose the MRI showing right MTS, EEG showing left temporal spikes, and seizures 1 or 2, some doubtful, then we need to record more seizures. So the question is, MRI is very easy. You just order, the patient will go to MRI center and will get it done. What about video EEG? Is it so easy to do? As you know that video EEG setup needs a separate room with an attendant stay, because if there is a seizure, you need somebody round the clock to help, at least to monitor the patient. Then a technical backup. Suppose there is seizure, we need to kind of do some testing. Suppose the EEG is not having some technical issues, technician should be able to come and correct it. So round the clock running machine in a separate room with a round the clock technical backup. And for how many hours? Short term, maybe just 2-3 hours. If somebody is getting every hour seizure. Overnight, if somebody is getting everyday seizure, maybe overnight to 24 hours. But if somebody is getting seizure once in 2-3 days or once in a week, we need to do long-term EEG. So in such scenarios, we stop anti-epileptic. And even if the seizures are coming once in a week to once in a month, the moment we stop anti-epileptic, we expect that patient is likely to get seizure in next 2 to 3 days. But in a given patient, we may have to record for 1 week or even more. So for that, you should have a machine which is free for 1 week. You should have a technician who is able to give backup for 1 week, and that room which can occupy for 1 week, or at least 2 to 3 days. So because of these challenges, the availability in India is not really good. You can count them on finger. And another aspect is mostly they are in southern India. We hardly have centers in northern India in government setup. In Delhi, in government setup, we hardly have anything in. It's quite unfortunate, but the fact is, either it is Himachal, or it is J&K, or it is Punjab government, or it is Haryana government, or even UP government, except KGMC and PGI Chandigarh. In Delhi, yes, AIMS and GB Pant are doing, and now probably Safdarjung is doing. But those limited centers, actually speaking, this facility should be available at all medical college level. So in corporate, the issue is of economy. Is it really economical? Cost effectiveness is an issue. For a per patient, you need to give a one room, a 24-hour technician, and a 24-hour available machine. So the cost calculation is one thing which corporate always thinks on. Bit difficult, but at least we are able to manage in last 10 years. Yes, many of our patients could not afford, and that has limited our numbers, but still we had a good number of setups and good number of video EEGs done. There are many charitable centers which are doing, and they are doing very good job. So there the cost is very, very minimal. When some government setups are doing it free of cost, some government setups are doing it at a very, very minimal cost. So that is one part which I think needs to be improved, needs to have more centers to help in patient of refractory epilepsy, because the number is huge. Next, come to the treatment. So suppose we diagnose that this patient is having refractory epilepsy. Now we want to treat it. So what are the options? First, always people prefer is, can we try medicines? Yes, there are some anti-inflammatory medicine. People do try steroids in pediatric population like West syndrome, LGS, and they do get good improvement. A patient who having autoimmune epilepsies, anti-inflammatory drugs are very good. There are some experimental drugs going on for drug-resistant gene blockage, which are should come in some how many years we don't know. Then comes special diets like ketogenic diet. Yes, it is having a big role in pediatric population, and there are people who are tolerating it well and have excellent response. Surgery is one thing which we can discuss today. What is epilepsy surgery, and when can we consider, and when can we consider? So first criteria is seizures occurring frequently or severe enough to be disabling. There is no criteria of frequency. There is no criteria of how often it should have and how severe it should be. It's not necessary to be GTCS. Any seizure which is disabling and disrupting the quality of life, causing impaired consciousness, or causing injury, this is enough to consider a patient for epilepsy surgery. What are the types of surgeries? So, broadly speaking, the epilepsy surgery is of two types. Resective, you resect that part which is responsible for seizures, and this is the having best results. Almost up to 90% of the patient have excellent result with resective surgeries. Then comes this disconnective surgery, corpus callosotomy, especially done for an LGS patient where the child is having recurrent head injuries due to drop attacks. You disconnect corpus callosum, child stops dropping. Child may continue to have seizures, but at least the frequent falls prevented and improves excellent quality of life in excellent way. Hemispherectomy is another disconnective surgery which is having very good role in selected patients where the one hemisphere is abnormal. Then comes this pacemaker therapy or neurostimulation. I'm sure you might have heard about VNS, vagus nerve stimulation, then deep brain stimulation. Then comes this RNS. It's not myasthenia RNS, it is responsive neurostimulation. We will just briefly discuss one by one. So, coming from the surgery point of view, the surgery, the best outcome, as we discussed, is temporal lobe epilepsy. But there should be a clear lesion, whether it is MTS, whether it is cavernoma, DNET, ganglioglioma. So all these are temporal lobe lesions which are responsible for refractory epilepsy. But there should be a one-side lesion and same side pathology found on video EEG. Then these patients have excellent response. One advice, especially for neurosurgeons, suppose somebody is having epilepsy and you see DNET or ganglioglioma or cavernoma, you just go and remove it. This should not happen. It should be done in a proper setup with ecology guidance, because many a time the lesion per se is not epileptogenic. It is surrounding area which is gliotic or dysplastic that is responsible for refractory epilepsy. So we do see patients who are operated for cavernomas or DNET and only the lesion is removed without touching anything else, and the patient is actually having no response in epilepsy or only very temporary response. I'll show you one video which is a patient who is having epilepsy. Let me see. I'm sure it's not running. So this child is having basically refractory epilepsy, some automatic movements, and chewing automatism. A classical patient had some aura, he removes blanket, becomes stare, then some oromandibular movements, not responding for 1 or 2 minutes. So classical 4 A's of temporal lobe epilepsy. Aura, he had some aura of fear, automatism, amnesia, and arrest. So 4 components were there, and you see his MRI. So this is the MRI. You can see this. See, the right hippocampus is absolutely normal. In 3 Tesla MRI, we can actually see 3 different layers of hippocampus. In the left side, the temporal horn is very prominent and hippocampus is very small. So this patient had temporal lobe epilepsy. This was year 2010, so almost 9 years back. This was our first patient whom we operated for temporal lobe epilepsy. And this patient is having excellent outcome, used to have seizures every week. He stopped having seizure after surgery. He stopped anti-epileptic 2-3 years later, and now last 5 years, no seizures, no medicine. The child used to stay at home, grown up, started going to college, then started driving and enjoying a comfortable life. And one more thing to share with you today is that our epilepsy program today, we had reached 100 epilepsy surgery. Today was our 100th case, again an MTS patient, and hopefully that patient should also do well. So epilepsy surgery is one thing which is a very effective therapy in selected patients. So the question is to cut or not to cut. What are the pros? Somebody taking 5 drugs, you reduce medicine. Many times you stop medicine, the anti-epileptic toxicity is gone. Somebody who is seizure free, it is a curative therapy, not a preventive therapy. Then other issues like behavior and cognitives are better. What are the cons? Cost. Yes, it's a costly procedure, but in government setups or in charitable setups, it's being done either free or at a very minimal cost. Like in some of my senior, like Dr. Rathod, my colleagues like Dr. Sujit Jagtap or Dr. Neeraj Baheti, they are doing it. Neeraj Baheti is doing in Nagpur. So many people are doing it at a very, very nominal cost. In corporate, yes, it's costly, and we are doing it, and we could reach today 100, and it's a very, very cost-effective procedure in the sense that in long run, that cost of medication and quality of life, those things improve, so the cost gets justified. There is a risk of surgery, there is a risk of anesthesia, no doubt. Out of 100, I can say at least 2-3 patients, one patient had meningitis but recovered, fortunate enough. 2-3 patient had 2 to 3% patient had transient weakness which improved. None of the patient at least became worse than before. So that is one thing. And outcome, at least I can say, is as good as 80 to 90%. Next comes the stimulation therapies. VNS, you know that it was there in 10 years back, then it went off because it was not available in India. Now it is again back and it's available in India. And there are 2 variants. One is kind of advanced version where it can give extra signal when there is a seizure. So 2 types of models are there. It's an effective procedure. The best part is just need to put a kind of coil over the vagus nerve. You don't need to open the brain. Outcome is excellent. Only daycare procedure. Excellent in the sense, I'm not saying that it's as far as epilepsy surgery, but almost 50% patient have improvement. And it improves over next 1 or 2 years. So some first 6 months, you may not see much of improvement. Over 1 year or 2 year, probably some change in the network, some changes at the central level, which starts having effect on seizures. Behavior definitely becomes better. Patient becomes more alert. Because of status, frequent seizures, hospitalization, which was used to be there, comes down. So that is one thing which can be considered in any patient whom we are not able to do any epilepsy surgery. So suppose somebody is having bilateral gliosis, bilateral MTS, patient who is not a candidate for surgery because the surgical area is in the motor cortex or any important area, then those patients we can consider vagus nerve stimulation. So hospitalization is just for a day or so. Then comes this RNS. So RNS is, as I mentioned, it's not myasthenia RNS, it is responsive neurostimulation. So this is the machine and there are electrodes. So suppose this part of the brain is producing epilepsy. So there are electrodes. The moment there is a signal change in these electrodes that seizure is going to happen, this pacemaker will pick up these things and will produce some stimulation in response to those signals and try to block those signals, try to abort the seizures. So that is the closed loop kind of cortical stimulation in response to EEG changes. So this is also new entity which is being tried, and I'm not saying that this is something like a 100% curative, but a good palliative response with significant reduction in, at least in the intensity of seizures or disability. Third is deep brain stimulation. This is also an entity which we know for Parkinson, but for DBS in epilepsy, yes, it's a very, very promising entity which at least we have an experience of almost 3 patients. And what I can say is the results were far better than what we expected in the beginning. We thought of something like 50% improvement, but out of my 2 patients out of 3 have more than 90% improvement. So deep brain stimulation is another thing which can be considered when we are not able to do epilepsy surgery because of region, like the lesion is sitting on some abnormal area, there are bilateral changes. So in those cases, one option is DBS. My second part of the talk is lacosamide. The lacosamide is, a new drug. So we need to kind of discuss few things about lacosamide. But I'm open to questions on refractory epilepsy, and we will answer. We'll try to have discussion on refractory epilepsy after my completing the session on lacosamide. So lacosamide at present is kind of approved for focal epilepsy in tablet form or syrup form in children up to 4 years of age, beyond 4 years of age. That is a very important figure just to understand what is lacosamide. So, this is resting membrane potential, and the channel is in the resting state. Because of sodium channel coming here, it gets depolarized, and this channel is open. So once it is open, the anti-epileptic drugs, or what happens without starting anti-epileptic drug, once it is open, the channel, this goes back and it starts getting closed. So repolarization is happening very fast. So once it is repolarized, again available for depolarization. So this cycle continues, because here the inactive state, this state is inactive state where anti-epileptic drugs are working. They make the channel inactive, but this inactive state is very fast, that is within milliseconds in a patient with classical anti-epileptic drugs. While with sodium, lacosamide, though it's a sodium channel drug, this inactive stage is prolonged. So it lasts beyond seconds. So because of this, the depolarization is slow, and its availability for repolarization and then going back to resting state is very, very slow. So this is the mechanism how it's different from carbamazepine or oxcarbazepine, that this inactive state is for a long period. So slow inactivation, and this is the first drug in this category. And slow inactivation is almost 100 to 1000 time frame greater than fast inactivation, which decrease in the prolonged firing. And this is unique, not shared by phenytoin or carbamazepine. So this is what happens, that during seizure, the channels remain open for a long period and signal continues to pass, while lacosamide control these signals and it changes the shape of the channel. There is another pharmacogenic property of lacosamide which is being discussed. I'm not saying it has been approved or proved, but yes, what they have mentioned, this collapsing response mediator protein CRMP2, which is responsible for neuronal response, axonal sprouting, differentiation. So this is reduced in patient from refractory epilepsy. So this actually affects sprouting, and the patient with refractory epilepsy starts having this abnormality. So because of this CRMP2 effect, the lacosamide modulates CRMP2 signal, which helps in kind of axonal outgrowth is changed, neurotrophins are changed in a positive way, and the refractory epilepsy, refractiness or epileptogenesis is affected by downregulation of NMDA and R2 receptor as well. So this is disease modifying effect. So one is anti-convergent effect, other is anti-epileptogenetic effect. Why? Because of role in epileptogenesis, but this is not yet kind of proved. Other is its effect on GABA A receptors, can affect run down the GABA, which is there in drug-resistant epilepsy, and this is in synchronization with levetiracetam. So a combination of lefcosamide and levetiracetam may be synergistic combination. Come to drug profile. So dose wise, we usually start with 50 mg twice daily, increase weekly to 100 by 100 mg. So suppose 100, then make it 200, can make 300. So usually the dose is up, maybe if the patient is lean and thin, stick it at just 100 mg BD. Obese patient, you can try up to 400, but beyond 400, it's not kind of more effective than 400 dose, though people have tried up to 600 milligrams. There are availability with oral medication or IV medication. Both are same. You can convert from oral to IV, IV to oral, no issues in the same doses. With renal impairment, yes, there is an issue, especially in the end-stage renal disease. The dose should be less. Maximum is 300. And in dialysis patient, it is removed by dialysis, so need to give extra dose. Hepatic, mild to moderate, again, maximum dose is 300. Severe, we should not give. Adverse effects, the most important aspect is this dizziness. Diplopia, as with carbamazepine overdose, headache and nausea. So if somebody is getting this dizziness, what you can do is decrease the dose slightly. If somebody is having dizziness with 200 milligram, make it 150. With 150, make it 100, and the patient will tolerate. There are some side effects like syncope. If it is happening, then slowly reduce and stop. So because there can be something like withdrawal seizure, so slow withdrawal is advised. Then this eosinophilia, DRESS, hypersensitivity is not that common as like carbamazepine, but if it is there, then it's better to discontinue. I'm not going into details of clinical evidence, trials. There are so many things. I'll just briefly touch upon that. Studies have mentioned up to 50% to 70% improvement. In status, 50% to 100% improvement. As an adjuvant, systemic review done by Medline and working up Google Scholar, many studies, 14 studies, 3,500 patients, and 50% reduction seen in almost 40 to 50 patients. Overall, 69% what they have mentioned that patient have responded. And other studies like refractory status epilepticus patient, they have found almost 65% patient had improvement. Side effect, as I mentioned you, dizziness is the most important side effect, and almost 20 means 1 in 5. Reduce the dose, patient improves. Ataxia, diplopia, same thing. Drowsiness, headache, nausea is not much of that. This coordination problem again is dose related. Otherwise, well tolerated. Almost 50% patient have some response. And for refractory status, a good drug. Dosing, starting same for 40 to 50. In IV, it is 400 mg loading dose. In children, there are studies where they have tried this beyond 4 years of age. 50% improvement, some say 60% improvement. Side effect wise, bit of drowsiness, unsteadiness, nausea, same thing. Otherwise, efficacy tolerability is quite good and has been tried in focal and generalized epilepsies. Then from Saudi also they have tried as an adjuvant therapy. As such, for refractory, even partial status, I think it can be one of the kind of drug of choice because it is helpful in focal epilepsy, and refractory status should be a very good therapeutic option. As an add-on, safety-wise, it was well tolerated in the majority of the patient, no major side effects. Quality of life wise, at least one thing is there, that it doesn't affect cognition. It doesn't affect mood. It doesn't affect quality of life. So, like at least in comparison to levetiracetam, there is no adverse impact on mood. So that is one thing we can think of. Then people have tolerated in monotherapy. That is another thing. And I do have patients who are having taking lacosamide on monotherapy. I do give lacosamide as monotherapy in patients, in elderly, in patient with renal transplant, kidney transplant patients, where levetiracetam is one option. If they have behavior issues, lacosamide becomes the first option than any other drug. IV is quite effective, we have already discussed, and the loading dose is 400 mg. Then you can give 200 mg BD. The only thing is, 400 mg BD should be given slowly. Cardiac safety wise, there were some issues in the very beginning. People, there are studies which say that it prolongs UT interval, can cause sudden death, but that is very, very, very rare. It can happen, but more common in patients who are taking higher dose, like 800 milligram. Okay, but less than 800, there was no change in QTC interval. So there can be slight increase in PR interval. So in cardiac patients who are having arrhythmias, those patients, yes, may not be a good choice. I'll share my one case, and I think then it should be over in 1 or 2 slides. This girl came to me she's under my follow-up for last, I think, 3-4 years. And father is an IAS. She was a school-going student at that time. And she's 18-year-old girl. She had seizures since 16 years of age, GTCS, all nocturnal, happening every 2 to 3 months. Birth history normal, milestone normal. So quite worried. The father was definitely worried. Nocturnal seizures. I did an EEG which was showing the generalized discharges. The discharges are more in the frontal region. There are some polyspiky pattern, but they were not classical idiopathic generalized discharge, because they were coming just 2 hertz, which was a bit different from idiopathic generalized or JME patient, where we see usually 3 or more than 3. At times they were 3 also, but there was a bit tendency for slow discharges. So with this kind of EEG, there are 2 possibilities we thought, because EEG is showing some frontal and generalized discharge, whether it is frontal lobe epilepsy because the patient had only nocturnal seizures, or it is idiopathic generalized epilepsy. These were the DDs. Patient was under treatment from somebody else. Patient was given sodium valproate in a very high dose, up to 2 gram. Even though she's a teenage, she was tried up to 2 gram per day, and unfortunately she had no response. Then she was given levetiracetam 3 gram per day. There was no response. Then she was added clobazam 20 milligram per day. This was done before they came to me. And in fact, this was the case we discussed with Dr. Radhakrishnan came once to visit us. We were fortunate to have him. And we thought of changing anti-epileptic drug. And we started lacosamide. With lacosamide, patient had excellent response, became seizure-free. Right now, she is doing her fashion and technology training. I think she has completed her 2 years. We could stop her valproate, we could stop her clobazam, and then levetiracetam. So this particular patient, I remember this was probably one of my initial patients where we used this lacosamide. So as such, to summarize, that many patients remains refractory. Options include polytherapy, surgery, ketogenic diet, steroids. Resective surgery is the best entity, but surgery should be discussed with the pros and cons. Stimulation wise, we have discussed about VNS, RNS, TBS, and polytherapy. When we do, we should do with a rational combination. Newer drugs are at least having lesser side effect. Lacosamide is promising to offer some anti-epileptogenesis or modifying effect, effective in refractory epilepsy. As an add-on, no negative impact on cognition and mood. oral to IV, IV to oral, no food interaction, no drug interaction. So overall, it's a new molecule, monotherapy possible, first add-on possible, emergency situation possible. Better such patient, refractory patient, any drug which is added early have better outcomes, especially lacosamide. And it has been compared with first-line drug and then found to be effective. So we can titrate rapidly. We don't have drug-drug interaction. Cognition-wise, there is no negativity, and twice daily dosing. Thank you. So now there are some questions. So first question is Dr. Srinivas, who is from Vizag. Which all are the drug of choice in status epilepticus? So as you know that in the at least 5 years back, 10 years back, we had only mainly one drug, that was phenytoin or fosphenytoin. There are many studies where they have compared phenytoin, fosphenytoin with sodium valproate and levetiracetam, and efficacy wise, at least there is no major change. Overall, you can use levetiracetam, advantage being no cardiac arrhythmias, no drug allergy. Sodium valproate can be used, especially patient where there is clear-cut idiopathic generalized epilepsy. Phenytoin use is somehow coming down in status epilepticus. I'll still say fosphenytoin is better than phenytoin, and if you want to use, better to use fosphenytoin. Rest is individual choice. Levetiracetam can be used. Lacosamide is very effective. I've seen in patients, especially with clear-cut focal pathology in the brain and causing status epilepticus. Next question is from Dr. Rajesh from Patna. In an Indian scenario, an adolescent patient who is on levetiracetam for long term and not getting benefited with, would you recommend lacosamide as add-on or an conversion with monotherapy, and what dose? See, this question is always there, that if somebody is not having control on one drug, shall we add or shall to convert? At least the combination of levetiracetam and lacosamide is having synergistic effect. So combination versus conversion, the traditional teaching is if somebody is having some response to the first drug, then add on. If the patient is having no response or not tolerating that drug, better to convert. So conversion is possible and add-on is also possible depending upon a scenario. Suppose you start patient on lacosamide, 50 milligram BD, increase to 100 milligram BD, go up to 150 or maximum 200. And you see that patient is not having any seizure. Maybe down the line, you taper levetiracetam and you can continue monotherapy with lacosamide. I hope you got the answers. Third question is from Dr. Kalyan. He is from Thrissur. How third generation anti-epileptic drugs score over conventional and other newer anti-epileptic drugs? So that's a very good question. I'll say there are some studies which have compared older with the newer anti-epileptic drugs. I won't say that conventional drugs are bad. Effectivity wise, conventional drugs are as effective as newer drugs. It is mainly in terms of side effects that conventional drugs are having more side effects than newer anti-epileptic drugs or third generation. So like teratogenicity, from teratogenicity point of view, conventional drugs are not that good compared to newer drugs. Similarly, drug interaction, because of enzyme induction, the conventional drugs are having a lot of interaction with ATT, with oral anticoagulant, with the immunosuppression. So third generation having an edge over conventional drug in those scenarios. Next question is from Dr. Pradeep Samant. He is from Pune. What is determining factor while choosing an anti-epileptic drug, especially in women patient with epilepsy? So again, a very important question. As you can understand that women with epilepsy is a big percentage of patients with epilepsy, and especially the childbearing age. See that at least what we can say, there are 2-3 things which we should discuss. One is what type of epilepsy. If it is focal epilepsy, then yes, you can think of carbamazepine, oxcarbazepine, levetiracetam. If it is generalized epilepsy, lamotrigine or levetiracetam. I would suggest that in suppose you are not able to pinpoint the type of epilepsy, levetiracetam can be a better choice than other drug, or lamotrigine is one option you can try. But most important thing, don't change anti-epileptic if the patient is already pregnant and the epilepsy is well controlled. In such scenario, because most of the organogenesis is already over before the diagnosis is made, and avoid sodium valproate. Next question is from Dr. T. Balakrishnan. He's from Chennai. How effective and safe in lacosamide in newly diagnosed epilepsy patient with psychiatric comorbidity? So as you know that psychiatric comorbidity is quite common in patients with epilepsy, and we should use the drug which at least is not having negative impact on psychiatric issues, like behavior issues can worsen with levetiracetam. So in such scenario, the drug of choice is maybe lamotrigine, or even carbamazepine is having positive impact. Lacosamide having no negative psychiatric comorbidities, no negative impact. So lacosamide can be safely used and is very effective, and can be used for newly diagnosed focal epilepsy in patients with psychiatric comorbidity. Next question is from Dr. Tarun Saha. He is from Siliguri. So he says that, do you prescribe lacosamide as a monotherapy in your patient? And Dr. Tarun, we already discussed about this. Yes, I have used lacosamide as monotherapy in patients, especially who are having transplant patients, in where suppose there is a clear cut, like post liver patient, liver transplant patient, many a time develop focal epilepsy because of some gliosis, because of some ICH or some stroke, and those patients when they develop seizures. So I don't prefer to give carbamazepine or oxcarbazepine. Then lacosamide is my probably first choice. So in those scenarios and in many other scenarios, I have used lacosamide as first as monotherapy, or in many a patient where we used not as first line, but we used as second or third line, and could taper the other drug and could put the patient on lacosamide monotherapy. Dr. Nitish is from Lucknow. He has asked one question: which are the drugs with which third generation AED lacosamide can be combined? So again, a very, very important question. See, lacosamide, as per literature, can be combined with any drug, including sodium channel blocking drugs. You can combine it with lamotrigine, you can combine it with carbamazepine, oxcarbazepine, because here the mechanism of action is different from conventional drugs. It is acting on slow inactivation. So effectivity is good whether you combine it with any drug, and especially with levetiracetam, they mentioned some kind of synergistic action. So from combination point of view, we don't have any contraindication to combine. Next question, I think this is the last question. And Dr. Prakash from Pune, and he says that patient with hepatic encephalopathy with status epilepticus, which drug is preferable? And we do feel have this scenario quite often, because our setup is quite prominent liver setup, and we have many, almost very good number of patients undergoing liver transplant, and we do have the status epilepticus scenario pre-transplant, post-transplant. Which drug is preferable? So I think I'll say that first drug is definitely levetiracetam, because of there is no action on hepatic things. Other drugs which can be used, people have used phenytoin, fosphenytoin. Even phenobarbital has been used. Lacosamide can be used. So these are the options, or even in our, at least in our ICU setup, they prefer to put the patient on midazolam infusion or propofol infusion if it is something like they need to keep patient intubated. So these are various options which can be given in patient with hepatic encephalopathy. And I think we are on time, and we have come to, I think, the end of the talk and discussion. And this is back to you. Hitesh, you want to say something?
No, sir, we can end with a take-home message for the viewers.
Okay. So the take-home message from my side is that lacosamide is an effective drug It's a relatively safe drug to use. You don't need to worry much about kind of at least idiosyncratic reactions, but start slow. And if you can tell the patient that you may feel a bit of giddiness, and in fact giddiness or ataxia or unsteadiness is almost 1 in 5. So you tell that if you start feeling that thing, reduce the dose, or keep that dose at that level, don't increase the dose. Other than this, I don't have any major concerns. QT interval wise, yes, maybe if somebody is having arrhythmia, it's better to avoid. Other than this, it's an effective drug for focal epilepsy, and is quite effective for focal epilepsy. Though drug resistance is still possible, patient with focal epilepsy may not respond with lacosamide, may have to try some other drug, or we discussed a lot about epilepsy surgery, and at least we are fortunate to have this setup of epilepsy surgery. And as I shared with you, we have done 100 surgeries today. Thank you, and thanks for giving time. Thanks to Lupin for this excellent setup.